Welcome to Basic Principles of Antimicrobial Therapy. This is a long presentation, so hang in there. Here are the objectives for this presentation and what you should learn from it. Antimicrobials are drugs that destroy microbes. They can prevent their multiplication or growth, or prevent their pathogenic action. They differ in their physical, chemical, and pharmacological properties. They also differ in their antibacterial spectrum of action and their mechanism of action. Antibiotics are but one type of antimicrobial. There are also antifungals and antivirals.
There are three in this relationship, and they are the drug, the host, and the bacteria. You can actually replace bacteria in this diagram with fungi or virus, etc. Each of the three interact with the other two. We will talk about the other types of infections, but mostly we are going to focus on bacterial infections. For example, bacteria cause infection in the host, and the host defenses will determine if the patient gets infected, and if the host does get infected, how serious the infection will be.
The discovery of the first antibiotic was an accident. Alexander Fleming accidentally contaminated a plate with a fungus. He observed a clearly defined region of no bacterial growth where the fungi had contaminated the plate. The area around the fungus was eventually referred to as the zone of inhibition. In 2016, over 270 million antibiotic prescriptions were written in the United States. That's enough antibiotic courses for 5 out of every 6 Americans on average to receive an antibiotic prescription. The CDC estimates that about 47 million of those prescriptions are prescribed for infections that don't need antibiotics. That's about 30% of all antibiotics prescribed. Another interesting fact is that farms are estimated to account for roughly 70% of total antibiotic sales in the United States. The problem is likely worse in the dozens of countries where antibiotics can be bought over the counter or on the internet. In 2015, the World Health Organization found antimicrobials were available without a prescription in more than half of the 133 countries that submitted data. Although we talk about how many prescriptions are necessary, I must emphasize the fact that antibiotics have increased the lifespan in the United States from approximately 47 years in 1900 to 78 years in 2010. Mortality from all causes dropped 54% over that time period. The top 3 causes of death in 1900 were pneumonia or influenza, tuberculosis, and gastrointestinal infections. Now the top causes of death are chronic diseases such as heart disease, cerebrovascular disease, and cancer. Antibiotics or antibacterials are drugs used to treat bacterial infections. There's a difference between the two. An antibacterial agent can be defined as substances from microorganisms, such as bacteria or fungi, or synthesized substances that produce bacteriostatic or bactericidal effects. Antibiotics, on the other hand, are defined as substances that are produced from microorganisms. They are not externally synthesized. We do use these terms interchangeably, but I did want you to realize there was a difference. Ideally, we would like a culture and sensitivity to identify the causative organism and antibiotic susceptibilities before we begin an antibiotic. First, let's define some other terms. Empiric therapy is the treatment of an infection before specific culture information has been reported or obtained. It is broad spectrum to cover the likely organisms. We will define spectrums on the next slide. Definitive therapy is when the organism has been defined and a specific therapy has been chosen. The antibiotic would have a more narrow spectrum. Prophylactic therapy is the treatment of antibiotics to prevent an infection, such as with intra-abdominal surgery. Bactericidal drugs are drugs that can kill the microorganisms. Bacteriostatic drugs arrest the growth or replication of the microorganism but cannot kill them. Eventually, the bacteria do die due to these restrictions on growth and reproduction. It should be noted that a drug may be bacteriostatic for one organism but bactericidal for another. The antimicrobial spectrum of a drug means the species of microorganisms that the drug can inhibit or kill. Narrow spectrum agents act on a single or limited group of microorganisms and are referred to as narrow spectrum antibiotics. For example, isoniazid is active only against mycobacteria. Broad spectrum refers to agents that affect a wide variety of microbial species. For example, tetracyclines, such as doxycycline, affects a broad spectrum of bacteria. Using broad spectrum antibiotics, however, interferes with the nature of normal bacterial flora and can precipitate a superinfection of an organism. Now we are going to review some of the types of bacteria. I have given you a handout under additional reading that has common organisms and the likely bacterial pathogen by site. Bacteria are also classified according to their shape. They have round cocci, the rod-like bacilli, and the spiral-shaped spirochetes. Let's talk a little bit about gram staining and gram-positive and gram-negative organisms. Graham's method helps distinguish between different types of bacteria. The gram staining characteristics of bacteria are denoted as positive or negative, depending on whether the bacteria take up and retain the crystal-violet stain or not. Here are gram-positive organisms you will encounter commonly in primary care: Streptococcus, Staphylococcus aureus, Enterococcus faecalis, and methicillin-resistant Staphylococcus aureus. They are all gram-positive organisms. E. coli, Klebsiella, Salmonella, Proteus, Pseudomonas, H. fluenza, and M. catarrhalis are all gram-negative organisms. You must know these organisms. Knowing if the likely organism is gram-positive or gram-negative helps you in determining the appropriate antibiotic to use.
Please review the handout for you that lists these bacteria and their sites. It's listed under required readings.
Drugs that inhibit bacterial cell wall synthesis or activate enzymes that disrupt the cell wall include the penicillins and cephalosporins. They weaken the cell wall and thereby promote bacterial lysis and death. Drugs that cause lethal inhibition of bacterial protein synthesis include the aminoglycosides, for example, gentamicin, and are the only drugs in this group. We do not know why inhibition of protein synthesis by these agents results in cell death. Drugs that cause non-lethal inhibition of protein synthesis include tetracyclines and macrolides. Like the aminoglycosides, these drugs inhibit bacterial protein synthesis. However, in contrast to the aminoglycosides, these agents only slow microbial growth. They do not kill bacteria at clinically achievable concentrations. The function of the bacteria is disrupted enough to eventually cause cell death. Drugs that inhibit bacterial synthesis of DNA and RNA or disrupt the DNA function include rifampin, metronidazole, and the fluoroquinolones. These drugs inhibit synthesis of DNA or RNA by binding directly to nucleic acids or by interacting with enzymes required for nucleic acid synthesis. Antimetabolites disrupt specific biochemical reactions. The result is either a decrease in the synthesis of essential cell constituents or synthesis of non-functional analogs of normal metabolites. Examples of antimetabolites include trimethoprim and the sulfonamides. This is the process in selecting an antibiotic. We will be reviewing each of these steps. You need to determine if the patient is infected. This process includes a careful history and physical exam, including the temperature, white blood cell count, any swelling or erythema, purulent drainage, and patient complaints. There are some predisposing factors to getting an infection, such as recent surgery or procedures, pre-existing conditions such as COPD, immunosuppression, frailty, malnutrition, exposure to others such as in a daycare or university dormitories, etc. It is best to identify the pathogen, but not always cost-effective or needed in primary care. An antibiogram is an overall profile of antimicrobial susceptibility testing results of a specific microorganism to a battery of antimicrobial drugs. This profile is generated by a lab using aggregate data from the hospital or healthcare system. Data are summarized periodically and presented showing percentages of organisms tested that are susceptible to a particular antimicrobial drug. Again, most antibiograms are from hospitals or healthcare systems, and those patients, as we know, are the worst of the worst for drug resistance. Data from an antibiogram do not take into account patient factors such as history of infection or past antimicrobial use. Resistance patterns for certain drugs vary significantly by age and a patient's underlying medical condition. But we can cautiously extrapolate this information to primary care. Antibiograms help guide the healthcare provider in selecting the best empiric antimicrobial treatment in the event of pending microbiology culture and sensitivity results. Here's an antibiogram for Chicago developed a few years ago from 27 hospitals. Look at E. coli. The only two antibiotics that are not IV are nitrofurantoin and TMP-SMX, which is Bactrim or Septra. TMP-SMX has a 26% resistance rate, so you probably should consider using nitrofurantoin instead. It has a 3% resistance rate. On culture and sensitivity results, the minimum inhibitory concentration, or MIC, is the lowest concentration of drug that prevents visible bacterial growth after 24 hours of incubation in a specified growth medium. It is organism and antimicrobial specific. Generally speaking, the lower the MIC, the better the antibiotic response, but the selection of the antibiotic depends on the pharmacokinetics of the drug's activity versus the organism, the site of infection, and the drug-resistant mechanisms. Obviously, S means that the microbe is susceptible to that antibiotic, R means its resistance, and I means intermediate. Avoid the resistant and the intermediate antibiotics. Some rules when looking at a culture and sensitivity report. Rule number 1. Always start with a beta-lactam if possible, especially in severe infections. Cephalosporins and penicillins, among others, are beta-lactams. They have a beta-lactam ring in their chemical structure. They have the best data supporting their use and are, in general, excellent drugs. Atypical infections, such as with the Mycoplasma pneumonia, are exceptions. Rule number 2. Do not compare MICs between drugs. The MIC is the minimum inhibitory concentration, and all numbers are not equal, meaning a less than 2 in one antibiotic is not the same as a less than 2 in another antibiotic. It is a long explanation that you really don't need to know, but the end result is that each antibiotic has different pharmacokinetics and pharmacodynamics. Generally, however, the lower the number is usually better, as it takes a lower concentration of the drug to produce its effects. You can use drugs with the less than and/or equal sign if you note these exceptions that we will demonstrate an example on the next slide. Here is a urine culture on a young adult female with cystitis and no other comorbidities. Note that the bacteria is Klebsiella. You need to eliminate the drugs that are resistant. Then you can eliminate the drugs that are intravenous, since this is an outpatient. For Rule 1, and this is looking at that last example, cefotetin and meropenem are the only sensitive beta-lactams. They are both IV. Rule 2 just states to not compare the mix between drugs. For rule number 3, the exceptions include that cefotetin should not be used for extended spectrum beta-lactamase producing organisms and is IV. Extended spectrum beta-lactamase organisms are gram-negative bacteria that produce an enzyme, beta-lactamase, that has the ability to break down commonly used antibiotics, such as penicillins and cephalosporins, and render them ineffective. Okay, to continue with the exceptions here, meropenem is appropriate but is IV. Ciprofloxacin is resistant, so levofloxacin should not be used. And anyway, it is very broad spectrum. Digoxin has poor urine penetration and is IV. Nitrofurantoin is the winner. Presumptive treatment is defined as a one-time treatment for a presumed infection in a person or group of people at high risk of infection. Most of the treatment in primary care is presumptive. Drug selection is based on the clinical evaluation and knowledge of microbes that are most likely to have caused the infection. We can do select point-of-care testing, such as a rapid strep test or a dipstick urinalysis. These will identify infection, but not the organism. Thus, you must know the organisms that are more likely in community-acquired infections by sight. Just a note about empiric therapy. Empiric therapy is antibiotic therapy for patients before causative organisms is positively identified. In primary care, we often do not do cultures unless the infection does not respond to treatment. Thus, most of our treatment is presumptive. In primary care, the choice of antibiotics should largely be determined by multiple considerations. The first is the source or site of infection. You do need to have the handout that lists the likely pathogens by site. You need to know these. You need to determine whether the infection is viral or bacterial. We will discuss this on the upcoming slides. You will need to determine the risk for antibiotic resistance. The age of the patient matters. If they are less than 2, in daycare, or older than 65, they are more likely to have antibiotic resistance. Using antibiotics within the last month will make them more prone to resistance. And of course, it could be a nosocomial infection from being in the hospital within the last 5 days. And we all know that hospitals are a cesspool of bacteria. If the patient has multiple comorbidities and are immunocompromised, they are also more likely to have resistance to antibiotics. But in primary care, the usual infections are community acquired. This is Tom, who is an 18-month-old male. He was brought in with a history of fever with rhinorrhea for 2 days, diarrhea, and a pretty good cough. His father has also been sick. On exam, his throat is congested, but no exudates identified. How will you manage this patient? Okay, we have clinically diagnosed him with a viral upper respiratory infection. In children, it is usually very common. We will give Tom symptomatic support, and antibiotics are not needed. In contrast, we have Bob. Bob is a 4.5-year-old male who is brought to your clinic with a 2-day history of high intermittent fever and mild cough, no exanthema. He does have difficulty swallowing, but there is no history of anyone else in the family being sick. He just looks like he doesn't feel good. On examination, Bob has a respiratory rate of 28, a heart rate of 110, and his blood pressure is normal. His temperature is 101.8 Fahrenheit. His right tonsil shows a purulent discharge with inflammation of both tonsils. He has bilateral tender cervical lymph nodes, but no ears or nose symptoms. How will you manage Bob? Bob probably needs an antibiotic. A rapid strep test can rule in strep throat or tonsillitis, but not rule it out. A negative test on Bob would need to be followed up with a strep culture. Here's a comparison of Tom and Bob. Notice the differences. Some good predictive signs for a virus include presence of watery nasal discharge, absence of pharyngeal erythema, absence of tonsillar exudate or follicles, absence of tender lymphadenopathy, involvement of multiple systems, generalized macular papular rashes, and a history of similar illness in the family or community. The greater the number of these signs and symptoms, the better the predictability of a virus. No single sign is definitive. In a child less than 3 years of age, the illness is more likely to be viral. These are some golden rules for judicious use of antimicrobials. Both viral and bacterial infections present with fever. If there is no fever, an antibiotic is not warranted. Infection is common, but they are not usually bacterial. Viral infections are the greatest majority, especially with respiratory tract infections. Clinical differentiation is possible between bacterial and viral infections most of the time. A viral infection is disseminated throughout the system, such as in an upper respiratory tract infection and a lower respiratory tract infection, and it may affect multiple systems. In a virus, fever is usually high at onset, but settles by day 3 or 4. A bacterial infection is localized to one part of the system, for example, tonsillitis, and does not present with runny nose or chest signs. Fever is generally moderate at the onset and peaks by day 3 to 4.
Chronic infections are a little bit of a different story. It may not be associated with fever, and diagnosis can be difficult. You need to order relevant laboratory tests and possibly x-rays to determine a diagnosis. Choose a single oral antibiotic, either covering the suspected gram-positive or negative organism as per site of infection and age of patient.
Golden rule number 6. At first visit, within 48 hours of fever, antibiotics are justified only if bacterial infection is clinically certain or very probable. I have patients who come in with a sore throat. When I ask them when the symptoms began, they often tell me last night or this morning. After examination, I have to explain to them the difference between a virus and a bacteria. I also explain about antibiotic resistance. All the while, I am confirming with them that they are really sick. I do not want to minimize their concerns. There are handouts under your required readings from the CDC that can be given to patients. An antibiotic could always be given later if really needed. You'll see more focus on using shorter courses of antibiotics. Longer courses are actually more likely to lead to resistance, partly by increasing our normal flora's exposure to antibiotics. We've already seen this shift. Up to 10 days used to be the norm for uncomplicated cystitis in women, but now we know that 3 days of TMP SMX is usually enough. Consider the type and severity of infection, antibiotic choice, and the patient, and resist the urge to use longer courses just in case. For community-acquired pneumonia, it's usually okay to stop antibiotics after just 5 days if the patient hasn't had a fever for 2 or 3 days and is otherwise stable. And 2 to 4 days is often all that's needed to treat cystitis in most school-age kids without a fever, instead of the traditional 7 to 14 days. If you're on the fence, reevaluate the patient's symptoms in a few days. But for strep throat, continue to give a 10-day course of penicillin or amoxicillin, even if the patients feel better. The full course is needed to eradicate the bug and possibly prevent rheumatic fever. Remind patients that antibiotics usually aren't needed for bronchitis, sinusitis, pink eye, etc., since these are typically viral. Please review the chart by prescriber's letter that is in your required readings. The therapeutic response must be monitored. We need to monitor clinical responses to treatment and laboratory results. The frequency of monitoring should increase with the severity of infection. Clinical indicators of success include reduction of fever and resolutions of signs and symptoms related to the affected organ. For a more minor infection, such as a UTI, we usually tell them that if symptoms worsen or are not better in 3 days, to call the office. For a more serious infection, we will have them return to the office in 1 to 3 days, but we also tell them what symptoms warrant an ER visit. We do not do serum drug levels for toxicity in primary care as is done in hospitals. We also do not do renal and hepatic function tests as follow-up. We do have labs for assessment prior to beginning treatment. The labs do not have to be recent. It may be from 6 months to up to a year ago. Over time, organisms develop resistance to antimicrobials. Initially, the microorganism might have been highly responsive and then became less susceptible to one or more drugs. I realize that the timeline is difficult to see. What you need to note is the discovery void, which refers to the period from 1987 until now. The last antibiotic class that was successfully introduced was discovered in 1987. Resistant infections occurred early in the days of antibiotic use, but a steady flow of new antibiotics provided alternative treatments. It was possible just to switch treatment once resistance against a specific antibiotic became a major concern. But then the antibiotics stopped coming. Since 1987, there's been a lack of innovation in the field, and today there are few novel antibiotic classes in the drug pipeline. There are 4 basic actions a microbe can develop to create resistance. The first is to decrease the concentration of a drug at its site of action, and it can either cease active uptake of certain drugs or increase active export of certain drugs. The second action is to inactivate a drug. Microbes can resist harm by producing drug metabolism enzymes such as penicillinase. The third action is to alter the structure of drug target molecules, mainly change the receptors for the antimicrobials. The fourth action is rarer, that the microbe may produce a drug antagonist to block the effects of the antimicrobial. The mechanisms to achieve these four basic actions are spontaneous mutation and conjugation. In spontaneous mutation, there are random changes in the microbe's DNA, which causes resistance to one drug. In conjugation, extrachromosomal DNA is transferred from one bacterium to another. This is usually caused by gram-negative bacteria and results in multiple drug resistance. It is innate in antibody properties that they promote resistance. Broad-spectrum antibiotics do the most to facilitate resistance. The more antibiotics are used, the faster drug-resistant organisms emerge, which is why we need to only use antibiotics when absolutely necessary. Drug resistance happens whether inappropriate prescribing or not. As stewards of antibiotics, we have responsibility to prescribe judiciously. We need to stay up to date and follow the appropriate prescribing guidelines. We need to not acquiesce to patients' requests for antibiotics for viral illnesses. We need to emphasize that patients adhere to the prescribed antibiotic regimens. The antibiotic must be present at the site of infection for a significant or sufficient length of time to be effective. And they must not be discontinued prematurely, so teach patients to complete the full prescription.
You need to know these 6 risk factors for antibiotic resistance. These include patients who are less than 2 or older than 65, patients who attend daycare, patients who have had prior antibiotics within the past month, or some even say 3 months, or prior hospitalization within the past 5 days, patients who have multiple comorbidities, or patients who are immunocompromised.
In summary, antimicrobials are essential components to treating infections. Appropriate selection of antimicrobials is more complicated than matching a drug to a bug. While a number of antimicrobials potentially can be considered, clinical efficacy, adverse effect profile, pharmacokinetic disposition, and cost ultimately guide therapy. Once an agent has been chosen, the dosage must be based upon the size of the patient, site of infection, route of elimination, and other factors. Use antimicrobials only when needed, for as short of a time period as needed to treat the infection to limit the emergence of bacterial resistance.